our last overall diabetic care symposium is focusing on our Indian practical aspects. So the speaker, Dr. Sanjeev Phatak, is the founder of Vijayaratna Diabetes Diagnosis and Treatment Center in Ahmedabad, and is one of the most reputed diabetologists and metabolic physician of Gujarat. He is the first diabetologist in India. He is a director of Juvenile Diabetic Association Ahmedabad, Joint Secretary of Gujarat Diabetes Association Ahmedabad, ex-president of PA,
Dr.
principal
Teli,
investigator of many
Dr.
key
Teli, you can
diabetes.
skip it.
Yes. Okay, so I think Dr. Sanjeev Phatak is quite known to all of us. Over to Dr. Phatak, please.
Sanjeev Phatak is nationally known, so no need
No,
for
no,
an
no, no.
introduction, you know.
No, my introduction looks so small in presence of all these big faculties. That's why I deliberately decided not to.
No. Come on.
Well, good evening, everyone, and my very, very sincere apologies for not being visible, probably because of some problem with my webcam of the laptop. I tried to fix it with Hardik also, but no fault from his end, probably some problem with my laptop. I hope I am audible, and I hope my screen can also be shared.
Yes.
Yeah? Okay. So let me share my screen. Kelly, is my screen visible?
Yes, it is visible.
It is visible, sir.
Thank you so much, and thank you very much, and congratulations, Dr. Banshi Sabu, a very close friend, just like a brother. And whatever I say for this Diacon conference or for Banshi Sabu, I am sure that it is going to be an understatement, because he continues to exceed all the expectations in all the meetings, whether they are real meetings or whether they are virtual or whether they are hybrid meetings, and sets the new bar every time, only to be broken by Bansi himself. So I'm very glad that we all are here on this virtual platform towards the end of this year. And I'll be talking about management of Indian diabetic dyslipidemia, meeting the goals to save lives. My disclosure is this is an AstraZeneca sponsored symposium, and I'm going to talk about rosuvastatin and the impact of lipids on our Indian diabetic patients. Well, we know that there are so many risk factors for our Indian diabetic patients. Male, age, the family history, whether you are living in a city or a small town or in a rural place, how much centrally obese you are, and whether you are having comorbidities like hypertension along with diabetes, and what is your income status, because income status also governs the amount of stress that you are going to get in your day-to-day life. But amongst all this, probably dyslipidemia has emerged and has remained as one of the most important factors that can be modified so as to reduce the cardiovascular risk, not only of the diabetic patient, but also of the non-diabetic population. The typical Indian phenotype, we know we are having high insulin resistance compared to the Caucasians. We have greater abdominal obesity, higher waist circumference, and the characteristic atherogenic dyslipidemia, where we have high TG, low HDL, high VLDL also because of high TG, and high small dense LDL in spite of a relatively normal looking LDL. This all leads not only to the susceptibility of diabetes, but also cardiovascular disease, especially the coronary artery disease. So at lower BMI, because of high central obesity and other insulin resistance factors, we have more cardiovascular disease. Very importantly, we have high waist circumference, high waist to hip ratio, low level of adipokine, and high plasma leptin, low rate of glucose disposal. And because of all this, we have increased insulin resistance, and that is coupled with impaired insulin secretion also. So not only we are having more insulin resistance, but our beta cells are also having problem, and this leads to more susceptibility of diabetes and ultimately cardiovascular disease. Unfortunately, in spite of so many new drugs available, still the control of HbA1c remains elusive in our Indian population. Also globally, the HbA1c average is about 8.1. In India, it is about 8.6, the average HbA1c. And in spite of the different new agents available, the overall control has not much improved. The actual target according to ADA is less than 7, according to ACE is less than 6.5. And we have agents which do not cause hypoglycemia. We should be trying to achieve less than 6.5, even 6. Normalize the blood sugar, achieve normoglycemia so as to reduce the cardiovascular as well as the microvascular complications. So there is definite need for appropriate treatment of Indian diabetics, both from the glycemic point of view as well as the lipid point of view. Needless to say, blood pressure control also plays an extremely important role in governing the cardiovascular risk of our diabetic patients. So in spite of the therapies available, there is a significant inertia, and this article was published by Mohan and Kamlesh Kunti in last decade, that patient-related as well as the clinician-related factors, the inertia because of us as well as by the patients leads to inappropriate control, undesirable control, and that leads to inadequate control, that leads to a lot of complications. We very well know the consequences of the delayed intervention. And this is a very important slide you might have seen several times, but I'll take just 1 minute to describe this. This is one patient population where the HbA1c was brought down within 6 months and then maintained below 7 for next 5 years. Compared to that, this is a set of population where HbA1c control was not achieved initially, and thereafter HbA1c treatment was intensified. Near normal target was achieved about 7, but the difference lies here, somewhere here between 6 and 12 months. And this is the period which I always call power play of diabetes. If there is power play in cricket, it is in the first 10-15 overs. If there is power play in diabetes, it is in the first 1 year. If you do not control intensively, you are going to build up a very bad glycemic memory, bad glycemic legacy, which at the end of 5.3 years in this meta-analysis showed significantly increased risk of MI, stroke, heart failure, as well as the composite of all these three. So not only blood pressure and lipid control are important, but also the blood sugar control is extremely important early on so as to have a better and better cardiovascular outcome. Let me try again whether I am visible or still I am invisible. Yes. So this bad glycemic legacy is the driver of late diabetes-related complications. All of us know this very well. So early and appropriate treatment is required for both, and hypertension also. We'll dwell upon dyslipidemia today. And the dyslipidemia status in our Indian patients, you can see that the prevalence of dyslipidemia is about 80%. In our study, in our clinic coming patient study, it is about 90%, which means abnormality of one of the three, maybe elevated LDL or low HDL or elevated triglyceride, and that is found in about 80 to 90% of our diabetic patients. In spite of giving statin, because they are not prescribed in the appropriate dose, only about 50% of the patients achieve the LDL goal that is given to them. And in spite of combination therapy being given, only about 54% achieve the goal, which means the things do not improve even if you give another agent along with statin. And the best way is obviously to increase the dose of statin or give the proper intensity statin right from the word go so as to achieve the LDL target. So we need to understand the appropriate treatment for the Indian diabetic dyslipidemic patients. In comparison with the Europeans, we developed cardiovascular disease a decade earlier. 10% of the heart attacks occur in Indians below the age of 40 years, and 52% occur below the age of 70 years. So before the age of 70, about 50% of the cardiovascular events that are going to happen in the lifetime, they occur at a relatively young or middle age and not in the old age. In the Interheart study also, Dyslipidemia appeared to be the strongest contributor of acute myocardial infarction in Indians. So dyslipidemia and mainly LDL, though there has been some studies done in Scandinavia and Spain recently published in JSCC and Lancet, I think, they have shown the importance of triglyceride and VLDL, but still LDL, because of the robust data available with it, remains the most important as well as the modifiable risk factor that can govern the cardiovascular event rate. Several trials and the meta-analysis of these trials have shown that if you reduce LDL by about 39 milligram by statin, we can reduce 21% risk of the major cardiovascular events. If it is a major coronary event, 24% reduction, revascularization, 24%, stroke, 15%, any vascular death, 12%, any death, 9%, and overall events, 21%. So 21% reduction if you reduce LDL by about 39. This figure may be even better if the LDL reduction is done more intensively. What do the guidelines suggest? LDL to trigger further clinical action. Very importantly, we should be calculating one of the score, the European score, also known as score, or the ACC/AHF suggested score, that is ASCVD. Myself, Bansi, Dharmendra, we published a paper on comparison of different scores in our Indian subsets. And we found that not only ASCVD, but probably the Q risk or the JBS probably more resembles or more represents our population as far as the cardiovascular risk is concerned. But at least follow one of the scoring system. What do the ESC guidelines say regarding the risk of our diabetic patient? If the score is less than 1, it is low risk. If young patient with type 1 diabetes less than 35 years of age or type 2 diabetes less than 50 without any other risk factor, he is a moderate risk. Most of our age or diabetes duration of 10 years or diabetes with any additional risk factor falls into high risk. And diabetes with target organ damage is a very, very high risk patient or extreme risk patient. According to the ESC guidelines, very high risk for diabetes is one. We'll focus on high intensity statin is recommended. There is a class 1 recommendation. And if the patient is having diabetes and age 40 to 75, whatever the baseline, you can have about 50 to 60% risk reduction. You can see that if LDL is reduced by more than 50% from the baseline, the risk from 11.2 goes down to 4.8, which means 57% reduction in the event rate. Compared to only 30% or 40% reduction will lead to reduction of about 20 to 30% or at most 40%. But if you reduce the LDL by 50%, you can achieve almost 60% reduction of the cardiovascular risk. And this is, I think, a very, very important observation from all the studies done on statin, that our target should not be a number only, but 50% or more from the baseline. And that obviously changes the number needed to treat. Routinely in the studies, you would have found that the number needed to treat to prevent one event or mortality is 63. If you achieve just 20% reduction of the LDL from the baseline. But if it is 50%, the number needed to treat goes down to 26. So again, a very important number whenever you are treating any patient with statin. Statin obviously are recommended as the first drug for LDL. Obviously, there is no doubt, no debate in that. How about triglycerides? Well, even with triglycerides, of course, when triglycerides are more than 500, our priority is to prevent pancreatitis, and that stage, probably patient may deserve a fibrate or some other therapy. But if the triglycerides are between 150 and 500, still statin. In 2016, it was stated that statin may be considered as the first drug. 2019 onwards, 2020, 2021, the guidelines clearly recommend statin as the first line drugs, even when the triglyceride is more than 200, even when the LDL is normal. What do ESC guidelines say? even the ESC guidelines also say that even if the triglyceride remains high, statins are recommended both for type 1 and type 2. And before introduction of any combination therapy, we must first be using the maximally tolerated dose of statin. If it is atorvastatin, we may use 80 milligram, or if it is rosuvastatin, 20 to 40 milligram. And obviously, because rosuvastatin can be used in lower dose, giving more benefit and equal degree of safety, rosuvastatin has become much preferred molecule these days. To the ADA 2020 and now the 2021 revision also recommend less than 40 years, and 40 translates to 30 for Indians, because as we already stated, the diabetic patients in India develop cardiovascular disease a decade earlier. So less than 30, no ASCVD, and no other additional risk factor, probably you may still go away without statin. But otherwise, these patients require statin, and especially if they are having cardiovascular disease, high dose statin, high intensity statin. More than 40 years, even in absence of ASCVD score of less than 20, still they are deserving moderate intensity statin. What, according to ADA 2020-21, high dose or high intensity statin, and what is moderate intensity? High intensity for Rosuva is 20 to 40, Atorva 40 to 80. And moderate intensity Rosuva 5 to 10, Atorva 10 to 20. We'll not discuss about the other statins because we rarely use them in India. What do 2020 and now 21 guidelines say for other combination therapies? Statin plus fibrate not been shown to improve atherosclerotic cardiovascular disease outcomes and generally not recommended. Same thing is repeated in 2021. Statin plus niacin, again, no benefit. The only supplement is about the eicosapentaenoic pentoic acid based upon the REDUCE-IT study that if the triglyceride remains high, addition of EPA may be considered in patients with high triglyceride after the appropriate statin therapy. Now, among statin, which statin we should choose? There have been several trials which have compared atorvastatin and rosuvastatin, but I'll discuss just one here, the Uranus study in diabetic patients. Age above 18 years, LDL at baseline more than 127. Patients were randomized either to rosuvastatin or atorvastatin, initially started with 10 milligram of both or either other, and then intensified based upon the LDL reduction. And you can see that with rosuvastatin 10 to 40 milligram compared to atorvastatin 10 to 80 milligram, the median dose was 10 to 20 for rosuva, 40 to 80 for atorva. The LDL reduction was much better with a statistically significant difference of p-value of 0.001 or less with rosuvastatin. HDL also went up with rosuvastatin. Triglyceride was similar. LDL-HDL ratio definitely in favor of rosuvastatin, and non-HDL also. And according to the Indian lipid guidelines, non-HDL along with LDL is a co-primary modifiable risk factor. So all these are statistically significant. LDL, the LDL-HDL ratio, and the non-HDL in favor of rosuvastatin compared to atorvastatin. And the number of patients who could achieve the goal, at that time the goal was 115, 81% in the rosuva group and 65% in the atorva group. And if the goal was less than 100, 65% in the rosuva group, only 33% in the atorva group. So if your target is lower, and which should be, obviously rosuvastatin is going to give you much more success rate compared to atorvastatin with equal degree of safety. And amongst the rosuvastatin, we now have different brands available in our country, but the innovator brand obviously has the advantage. Not only the efficacy range will be better, but the safety, because of the impurities associated in some of the brands, may play a key role in increasing the side effects, especially the myalgia or some other side effects. Is there an evidence that compared to generics, innovators will have better outcomes? And this is a study from Spain where it was shown that compared to generics, the cardiovascular event rate was less in the patients who were on the innovator agents. The adjusted all-cause death was significantly higher with generics and lower with the innovator brand, meaning thereby that especially in the cardiovascular risk reduction, the risk of side effects as well as the efficacy probably is towards the use of the innovator brand compared to the generic brand. Why this occurs? Probably in the statins, and especially in the rosuvastatin, the impurities of lactone, anti-isomer, the 5-keto acids are probably not taken care of. And these impurities may be responsible for affecting the stability of the drug, increasing the side effect of the drug, and also reducing the efficacy of the drug. We are very much aware about what happened with the methylated impurity in the generics with atorvastatin. And we are also now aware about the NDMA impurity of metformin. So definitely these impurities play an important role in deciding the efficacy as well as the safety or the side effects of the drugs. So to conclude, we know very well that the risk of CVD is higher in Indian patients, and the most important modifiable factor for that is reduction of the LDL cholesterol. Guidelines recommend setting of LDL goals and statin as the first-line therapy to reach these goals set for the specific level of risk. Guidelines also suggest to consider intensification of statin to the maximum tolerated dose before going to the combination therapy. Rosuvastatin helps reduce LDL by about 52%, TG by 21% in diabetic dyslipidemia patients, and to have optimum efficacy, probably the original statin may have an edge over the generic brands. This I would end here, and thank you very much,